have some exciting upcoming PHIND seminars, and including one that we're about to hear about today in the area of biomarkers and also cancer progression for the upcoming ones. So we'll hear from some excellent investigators, and we're looking forward to learning more about sweat and being able to use that for risk assessment as well as understanding cancer progression. So we're really excited to have everyone present here today, and we have two very impressive speakers to tell us about wearable space and data and other interesting technology that they're working on. And this is actually a special seminar because they are co-sponsored by the eWare initiative. So we're very lucky to have them. We absolutely look for partnering opportunities when possible to try and do these joint seminars when possible. So I'll actually let Angela tell you a bit about eWare in case some of you may not be familiar with this initiative.
Oh, thank you so much, Ryan. Yes, I'm Angela McIntyre. I'm the Executive Director of eWare. It's the Stanford Wearable Electronics Initiative, and we foster collaboration to solve technical challenges that will increase the usefulness of wearables for future generations. So eWare is cross-disciplinary, and so we engage researchers with different areas of expertise, both in academia and in industry. Right now we have 13 industrial members, and we're always happy to have other members join us. I'm always so surprised to find out about the breadth of research related to wearables happening at Stanford. There's more than 50 professors that I've talked to so far that have some sort of research related to wearables. And it's just wonderful being able to have such a good collaboration and synergy with PHIND when we have topics like these that really are appealing to both of our memberships, because they have to do with you know, personal health and integrated diagnostics as well as be a wearables topic.
Excellent. Well, thanks so much, Angela. Yeah, it's always a pleasure to co-host things with you. So we're very excited to hear from Anoop Rao today on wearable sensing for neonates. So Anoop is a clinical instructor in pediatrics, part of neonatology. He is at Lucile Packard Children's Hospital, and after completing early medical training in India, he obtained his MS from MIT and completed clinical training in pediatrics from Columbia and fellowships in neonatal critical care from Stanford and biomedical informatics from Harvard. He spent over 5 years at Acknowledgement, a startup focused on developing high-accuracy blood glucose meters. And at Stanford, his research is on contact and non-contact monitoring for infants. Anoop collaborates extensively with industry and is actively supported by NIH Maternal and Child Health Research Institute. So we're very lucky to have him here today, as well as our other speaker. And just one thing before we hand it over to him is, so we'll have both speakers present, and then we'll have a question and answer session at the end for both. So at this point, Anoop, please take it away.
Thanks, Ryan. Let me just Is that visible?
Yes.
Okay, thank you. Ryan, thank you very much for the invitation. Angela, the eWare initiative is such a fabulous initiative in terms of some of the work that that we do at the Lucile Packard Children's Hospital, and I really commend both of you for sort of putting this together and trying to push the agenda forward. My name is Anoop Rao. I am a physician at the Lucile Packard Children's Hospital, and super happy to be here and love to actually share what we have. Before I start, I'd like to share an open invitation with anyone who's here today on the call. If you're interested to learn more, please swing by the hospital once the COVID situation's been taken care of, and I'd be happy to walk you through the hospital and share some of the stories that we have, where I personally think technology has played an immense role in improving the lives of some of the most vulnerable patients that we have. Sort of my disclosure here, I'll be talking about a few devices. I'm not endorsing them for any kind of clinical use just yet. I'm going to share some photographs that are not pleasant looking. So if you don't like them, I'm just giving you a warning right away. I'll start off by taking you back in time. This is from 1963. This is President John F. Kennedy walking into the Otis Air Force Base hospital, where he's just about to tell his wife the tragic demise of their child, Patrick. Patrick was just a day and a half old, and he was born at 37 weeks. And 37 weeks, by all means, is not a bad age to be born at. It's wonderful. Most babies today just survive and don't even bat an eyelid. But this was back in 1963. The technology wasn't available then. He died after a day and a half from a simple medical condition. We can call it simple today, but at that time it was pretty formidable. The condition was called hyaline membrane disease. It's sort of the bread and butter of many of the neonatal ICU units across the world these days, and it's not a big issue at all. But like I said, back then, this was an issue. Today, babies at 23 weeks, 24 weeks, 25 weeks are born, and many of them end up doing okay. So the reason I call this a pivotal moment in neonatal critical care is because shortly after this tragic incident, President Kennedy signed a bill that allocated significant amount of funding for neonatal critical care. And what we're seeing today is, the history can be traced back to some of the key advances that were made after this particular incident. And this was about 3 months before he was assassinated. So you can imagine there was this window in which many of the things happened, and this was one of them. And I take you back in time because the rest of my talk sort of is based on this particular fundamental idea that we have established. So I'm going to talk about 3 different areas of work that we do at the hospital. And I'm going to briefly touch upon these 3 devices just to give you a flavor of what we currently do and what we're really interested to actually work on in the next couple of years. At the hospital, I have the privilege and honor of working with very small babies. Babies who are born too early, too small, and often very sick. And here's an example. This is from about 6 months ago. The entire team here is gathered to save one critically ill baby who's hiding here in the background. This is a great snapshot of teamwork and is also something that shows the amount of technology that is being used these days to save babies. And I've labeled many of these things here. It's kind of ironic that the stethoscope is kind of banished to one corner right here. You got blood gas sensing, you've got cutaneous carbon dioxide sensing. There's a huge clunky machine here that looks like a microwave, but it's the mainstay of ventilatory management for babies who are born very early. There's some vital sign monitoring. The list goes on. There's some near-infrared spectroscopy. The list goes on and on. Tons of gadgets and sensors that we use. But this is not enough. I personally think there is a lot of room for more development, for collaboration that can actually lay the basis for the next round of innovation in neonatal critical care. I'll share an example right now, but the most important thing to think about when we're talking about very small babies, as one would have guessed, is that size really matters. And here's some drink for thought, if you will. This is a 38, 37 week term baby. who's fully baked, if you will. And that baby can roughly, you can equate it to about 5 cans of soda. In contrast, a premature baby here who's probably born at 26 weeks, 27 weeks, and sometimes smaller, 23 and 24 weeks, they can be as small as 1.5 cans of soda. So you can get the context here. Just to drive home the point further, this is an adult person's hand, and you can see right here in proportion what a small baby's wrist can be like. The reason I point this out is it relates to the next example that I'm going to show you. When we want to measure blood pressure in a very small baby, we do a procedure called as arterial line placement. And arterial line placement can be very painful. You essentially take a needle and a catheter and stick it into the wrist or a foot of a baby, and it's obviously very painful. Sometimes we go in blind without any any ultrasonic assessment of where the artery is and poke a bunch of times. Now, once we do this procedure, this is what the catheter looks like in cross section. You can imagine then when this plastic comes in contact with the blood, you can actually have clots form, and that's not great because these clots can cause the limb to not get enough blood supply. And I'll show you an example. So just to put in perspective, in order to capture the blood pressure, we put in these catheters. This is a peripheral arterial line because it's put in the periphery, in the hand or wrist. And this is a central line. This is a catheter that's placed through the belly button that goes close to the heart. Both these procedures have complications and clots can form. What can happen is if blood doesn't flow well into the wrist, the tips of the fingers can become dark. And if it's really bad, the entire limb can turn dark and you may have to amputate that limb to be able to save the child. Now, the question then comes, is there a much more less invasive way to be able to capture the blood pressure continuously in very sick babies who are small? And that idea then led me to Janan Bao's group. Professor Bao has worked incessantly in this space and many more. But at the core of this is a capacitance-based approach to be able to capture pulses. And these pulse waveforms retain a lot of the rich information that can be used to capture the blood pressure information. And so some of this work got spun out as a company named Pyramis, based here in Cupertino, and a great collaborator of ours. And Pyramis has created this wonderful sensor. This rectangular portion here is the sensing element. It's small, very lightweight, paper thin. It's extremely sensitive. It's very soft, so it doesn't really damage the skin of these premature babies who are very prone to damage. And so in cross section, this is what it looks like. The baby wears this wrist band. The sensing element captures minor fluctuations of the capacitance that happen on the skin as a result of the arterial wall fluctuating. And this information is then processed using a neural network model to be able to compute the systolic, diastolic, and mean arterial pressure. The neural network model is derived from arterial waveforms that have previously been recorded from other babies who've been admitted to the hospital here at Stanford or anywhere else. So once this neural network model is in place, capacitance waveforms can easily be transformed into arterial blood pressure waveforms. And just to sort of give you a 50,000 foot view, the baby wears the sensor. All that data is wirelessly relayed to a phone pretty close to the baby, and we then compute the blood pressure variables. Now, is this how useful is this? If you think about it, what we just described was the current standard of care is a very invasive method to be able to capture arterial waveforms. It's very time intensive, minimum of about 45 minutes to be able to start and finish an arterial waveform if you get it in 1 or 2 tries. it's very skill intensive. Not just everyone can do this. And of course, like I said, there are lots of complications associated with it. We've taken that procedure, and with Professor Bao's work and the entire team at Pyramis, we've been able to convert that into an easy to use, it's a non-invasive technique. There's no blood loss. You can just wrap around the wrist or foot, and I'll show you that in a little while that our initial data suggests that it's accurate, and in general there is no need for any calibration to be able to get these data. So we looked at about 36 babies worth of data, and this is a comparison between the arterial line gold standard method of capturing blood pressure on the x-axis versus the sensor-based approach to capture the data that's represented on the y-axis. And as you can see, they're kind of lined up in such a way that there is good enough correlation between the two data points. And from an accuracy perspective, it meets the FDA criteria for accuracy. To drive home the point that these neural network models that have been generated, they've been generated for neonates. And so I'm very happy to also mention that as of about 3 weeks ago, this device has been granted the FDA breakthrough designation for blood pressure management in neonates. And so what this suggests is our ability to use state-of-the-art computing methodology as well as wonderful sensors that have been developed here at Stanford itself to be able to take a very invasive procedure and convert it into a pleasant and non-invasive one. To be able to get good quality data so that clinicians like me can make decisions in favor of the baby. Like I mentioned, we've captured a whole bunch of data for a wide range of ages, babies that are as small as 460 grams to about 3 kilograms or so, babies born prematurely and straight up till term, babies with all sorts of cardiovascular plumbing problems, all sorts of post-surgical babies. So it's a wide range of babies that we've been able to capture data for. And like I mentioned, we've been able to get the FDA breakthrough designation for this device. And thanks to a tremendous amount of effort that has been done at Pyramis, as well as Professor Jinan Bao's lab. Let me change gears a little bit. And this is something from the website. I just want to drive home the point. This is a mother holding the baby. And as you can see, I still want to drive home the point of the sense of proportion. This baby would have probably had 5-6 attempts to get an arterial line in, but because we use the sensor from Pyramis, this actual baby was one of the participants in our clinical study. So you can imagine there was a wristband around this baby's wrist that was that allowed us to actually capture the blood pressure. Now, this photograph is also important for other reason. This is an excellent demonstration of something that we call as Kangaroo Care. And this caricature on the left shows you why we call it Kangaroo Care. Kangaroo Care has tremendous advantages. It allows babies to maintain good physiological balance, and their time to go home is faster, and there are multiple advantages. And the reason I bring this up is a lead-in to the next area of work that we do, which is fabric-based acquisition of ECG and vital signs. Our partner in crime here is GE Global Research. Ryan is familiar with this work, and he's been instrumental in supporting work like this. The typical baby in the ICU has a bunch of wires and tubes sticking out most often. And so if you were to ask any parent to hold this baby, they're usually very apprehensive because they feel that if one of these things is dislodged, that may harm the baby. So you can imagine that there is that push towards making things as unobtrusive as possible. And so in this particular project, we said, hey, can we eliminate wires and adhesive leads? And the technology is out there. And G has done a tremendous amount of work in this area. So we went through umpteen designs, and I believe eWare Initiative has previously been part of similar work earlier as well. And so we made a bunch of designs with horizontal electrodes, with square electrodes, looked at the configuration of electrodes and the amount of um, the interference, background interference, the ability to actually capture good waveforms and so on and so forth. And with a lot of trial and error, we hit upon a certain design with a square electrode configuration. Here, as you can see, the baby lays on top of this electrode such that the back comes in contact with the electrodes itself. And this is the configuration that we've tested out in our ICU. A ton of trial and error, I must say, that has gone on at GE's end to be able to get the best combination of electrodes. We've been also able to make a wireless configuration of this electrode, fabric integrated electrode, so that all you have to do is wrap the baby in this onsie or a cloth, and you'll be able to capture the ECGs. This is work that was ongoing before COVID struck. So this work is pending, and I can share some early data with you just to give you a sense of what we did. Right at the bottom is your standard electrode derived ECG signal. Right in the second panel right here is the unfiltered signal coming out of the fabric integrated electrode, and this is a filtered sample. Now, this was done in a baby who was extremely prone for skin damage upon using standard adhesive electrodes. And for babies like that and babies who are very premature, this is a method that we really want to look at. Now, I just wanted to give you two examples of sort of wearable sensing that we adopt in the NICU. I'll take a third completely different angle to this whole philosophy, and that is, are we cost effective when we're doing things like this? So I want to bring in an example of where Stanford's contributed to this initiative on reverse innovation. To put things in perspective, close to a fifth of our GDP is going to get used up for healthcare related expenditure. And so it's important for us to think, when we're going after gizmos and the next best thing, the next shining light, then it's important for us to think about how much cost of care that all of this impacts. And so this is a good example. Typically, an area of monitoring within the ICU setup roughly costs about 150 to 200K of sunk investment. So you can imagine a large ICU with 20, 30 beds. That's a lot of money to be using up. And so one of the interesting examples that we've been working on is a method of vital sign monitoring that allows us to capture multi-patient sensing data in a very cost-effective way. And this example here is of a unit that we've been collaborating with, where we can monitor babies, up to about 8 to 12 babies, for less than $1 per patient per day in an ICU setting. And so many of you may be familiar with a device named Owlet, and I'm sure it's a wonderful device, and they capture a lot of vital sign data, but this particular monitor has been able to capture heart rate, respiration, pulse ox, you name it, and anything that an ICU would definitely want to have, but at a cost that is very, very reasonable and at a cost that we should all be thinking about. So I think in the grand scheme of things, I just wanted to thank PHIND and the eWare initiative to be able to allow me to give a glimpse of what is capable, what we're capable of here within the Stanford Neonatology division in establishing certain partnerships with key people around the Bay Area and elsewhere, especially with industry support, to be able to do some excellent work, all in the interest of making sure our babies get the most benefit out of technology that is out there, as well as be able to think about cost effectiveness of care by partnering with other like-minded people. So again, I do extend the invitation to all of you to be able to reach out. And if you're interested to learn more, please shoot me an email, and I'd be very happy to take you around the ICU once the COVID situation is sorted out. Thank you very much.
Thank you so much, Anoop. Wow, that was wonderful to hear about the technology and all that you're doing to really improve the chances for these little ones. And oh, you were mentioning all of the issues that could come up when you're trying to save their lives and give them medical care, and the non-invasive treatment certainly seem like the way to go. Thank you so much.
Thank you.
We'll be taking questions for Anoop at the end of the webinar. And so we'll go now to our next speaker, and he will be talking about crowdsourced data and machine learning to design the future of prenatal care. I'd like to introduce Dr. Eric Dye. Eric Dye is the co-founder and CEO of Bloomlife, a women's health company designing remote prenatal care solutions to improve the health of women and babies. Eric brings unique perspective on the opportunities and challenges in emerging healthcare technologies and delivery models informed by multidisciplinary technical expertise, leading business development for Europe's R&D Institute, IMEC. Eric earned his Bachelor of Science in Bioengineering from Cornell and his Master of Science and Ph.D. in Biomedical Engineering from UCLA. Bloomlife has been recognized for their pioneering work, winning several awards: Fast Company World-Changing Ideas, Johnson & Johnson Quickfire Challenge, Richard Branson's Extreme Tech Challenge, MedTech Inventor Award, and speaking at the White House Precision Public Health Summit. I was very fortunate to come across Eric because his technology has been in the news, and it seems like in the future perhaps there will be synergies between what you'll hear about today and other research projects that will be going on at Stanford. Eric, thank you for sharing your slides.
All right, I'm unmuted. Great, so it's a pleasure to be with everyone here today. Thank you for the invitation. So yeah, Anoop sort of talked about, some of the technologies that are coming out for monitoring of babies that end up in the NICU. And part of our goal at Bloomlife is to see how do we prevent that from happening in the first place. So in terms of what I'd like to cover today, there's two really kind of key topics. One is just to kind of highlight how we see this interesting convergence of consumer medical markets. And not just, I think, from if people think about the consumerization of healthcare, about trying to, to think about the patient experience more. But from our side, there's also an interesting technological component of convergence of these two markets, and how the consequence of that is really it's opening up this possibility of building unique longitudinal data sets at a speed, cost, and fidelity that really wasn't possible before. And through these data sets, we're really opening the possibility of transforming our fundamental understanding of health and disease. The other thing I'll talk about really is this concept applied into maternal health, and how we have been approaching really looking at crowdsourcing data to really help solve some of the biggest problems facing maternal health globally, preterm birth, of course, being one of them. So those are kind of two main topics. And my sort of foray into this space, as was highlighted by Angela in sort of the introduction, was kind of a combination of where I was at professionally and personally in my life. So professionally, a lot of the concepts behind Bloomlife came when I was working at this Belgian-based research institute called IMEC. It's a very interesting place if anyone's not familiar with it. They're really one of the pioneers of Moore's Law and enabling next generation semiconductor technology nodes. But beyond making transistors smaller, one of the areas of business there was in mobile health and developing remote patient monitoring technology. So they're just kind of wearable devices. And I was originally there as a postdoc, switched into business development. And while leading business development for them, I found that we were finding partners and licensing our technologies and doing joint development projects with companies both in the medical space and the consumer space. And these were things for cardiac monitoring, brain monitoring, general health and wellness monitoring. And the interesting insight I had was that, we were taking a specific technology and doing a joint development project with a medical device company that was then planning on, obviously taking this to the FDA and selling to the healthcare markets and probably charging, $5,000 to $10,000 per device, and taking the exact same technology and then doing projects with consumer electronics companies that were then going to take this into the wellness market and sell them for $300. And while the markets and the applications and the ultimate requirements to meet the needs of the customers might be different for those two markets, fundamentally the technology that's powering these things is the same. And the implications of that in terms of where data, valuable clinical data can come from to drive an understanding of health and wellness and disease really was profound for us. And that was sort of something that was sticking in the back of my head as we were sort of, my co-founder and I were ideating around ideas. And then the other thing that was happening at the time was I was on a very long journey to start my own family, and had, you know, a lot of miscarriages, a lot of failed rounds of IVF treatments, and ultimately had a high-risk pregnancy with many complications ranging from, you know, placental complications, gestational diabetes, preeclampsia, ultimately a preterm birth, postpartum hemorrhage. And the thing that struck me was that there's so many unanswered questions for people at this time, and where the implications of not having good answers was significant, and significant not just for the patient and for the family, but really significant from a clinical decision-making standpoint. And we felt there was really unique opportunities to apply a lot of technology know-how that we developed in other therapeutic areas and bring it into maternal health. But to go back to this idea of the sort of crowdsourcing or the sort of convergence of consumer medical markets, we are already seeing what the implications of this can be, right? And how this convergence of consumer medical can really radically accelerate medical discovery. And two really just kind of great examples I like to use. I'm sure everyone here is familiar with 23andMe. 23andMe, when they sort of launched, many people saw them as this, you know, consumer health company that was selling, you know, genetic tests to consumers at $100 to $200 a pop, and we're just providing them, you know, general feedback around their their heredity, or, you know, where their family gene line might come from, or what color their eyes were, and sort of kind of a fun and just kind of interesting thing to do. But really, what was happening is behind the scene, they were amassing a very, very large genomic data set. And they were pairing that with self-reported data from patients, you know, through an app that would further enrich their data. And over time, and granted this took them some time to build this large data set, but they've essentially amassed, to my knowledge, the largest genomic data set in the world, and have since then started using this data to partner with pharmaceutical companies to start identifying new potential targets for therapies, for genetic therapies, and to start mining this data set in specific disease areas to see, can we identify the underlying genes that are connected to specific diseases? Can we use those genes to develop new therapies? And again, it's something that, if you think about the traditional way of collecting, you know, this large genomic data set, I mean, you're seeking grant funding, you know, it's taking years and years and years and years and years just to recruit a fraction of the people that they have. And they've been able to do this in a way that, while I'm sure they aren't probably making money on these individual sort of consumer tests, they're really subsidizing the actual cost of collecting the genomic data set. And they're already seeing the results of this bear fruit, not just through partnerships, but actually novel screening and diagnostic tests. And the other example I like to use, and again, this is sort of coming from the Stanford community, is what Apple's done with the Apple Heart Study. And, you know, I'm sure most folks are probably familiar with this, but, you know, the idea is that using essentially a consumer device, can this be used as a frontline screening tool for cardiovascular disease, or in this case, arrhythmias? And the thing that I find so interesting about the Apple Heart Study, and I think one thing that, again, that speaks to why this convergence of consumer medical will really massively accelerate clinical breakthroughs and discovery is what's highlighted here, is that this is the largest study of its kind, which enrolled over 400,000 participants from all 50 states in only a span of 8 months. And for anyone who's familiar with you know, any kind of clinical trial, usually the limiting factor is always the time it takes to recruit patients and the cost it takes to recruit patients. And one of the quotes, again, from a medical director down at Stanford is, you know, to get 10,000 people enrolled in a medical study would normally take a year and 50 medical centers around the country. A year, of course, is a lot of time. I can tell you it takes way longer than a year to get 50 medical centers to agree to any sort of, you know, any sort of large agreement of a study of this kind. And ultimately, Apple was able to get 400,000 participants in less than a year. And I think it speaks to how clinical trials in the future will take place once you have technology that's commonplace in people's lives that still has the level of quality that one would need for a medical device, but where the cost of it is ultimately, and the accessibility of it is radically different. And so these are, again, two kind of great examples, I think, that highlight that kind of first point. And how this relates within to the maternal health space, and just to kind of give you a little bit of background around what the situation is, we know that the period from conception through the first 1,000 days of life are the most critical for lifelong health and development of a child. That being said, in the US specifically, we're doing a pretty terrible job of managing this time of life. A few stats to share with you. In the US, we spend well over $100 billion a year on pregnancy and childbirth. We rank near last, if not dead last, of industrialized nations in birth outcomes. High-risk pregnancies and pregnancy complications are on the rise. Over the past 2 or 3 decades, we've seen a doubling of maternal deaths. Preterm birth, which Anoop sort of talked about before, is the single biggest problem in obstetrics today. That's when the babies are born early. They have increased risk of mortality, increased risk of lifelong morbidity, and they cost the healthcare system a huge sum of money. And all while these problems are sort of continuing to grow, access to care is becoming a problem. In the US, over 50% of counties lack a single OBGYN. And so for many women, they need to travel over an hour to 2 hours just to get basic obstetric services. So these are huge, huge, huge problems. And despite the fact that these things exist and are growing, the way that we deliver prenatal care, it fundamentally has not changed in over 50 years. Prenatal care is still centered around spot checks at the doctor's office using some pretty antiquated technology. What's shown in the back there is a device called a cardiotocogram. It was developed in the 50s, and it fundamentally hasn't changed. It's a device to measure contractions of fetal heart rate. As you can see, it doesn't look like the most comfortable device. Pretty much everyone hates it, from the doctors, the nurses, to the patients, but it's still really what we're working with today. The other aspect is, because of the consequence of how we deliver care and with the technology that we're using, a lot of known risk factors are very poorly addressed. Things such as chronic stress, sleep problems. These are things that are known to increase risk for preterm birth, but we haven't really figured out how to monitor and how to manage within current prenatal care. And as a consequence of all this, really both doctors and moms are really working with insufficient data for the patient to really understand what's happening, to be more proactive in managing of their pregnancy, and insufficient data for the care providers in screening and predicting of all major conditions. And at Bloomlife, this is what we intend to change. And really the goal is to start, in a way, digitizing pregnancy and building these foundational data sets for next-gen screening and diagnostics, and overcoming, and this is one of my favorite examples of how antiquated much of how prenatal care is and has been, is trying to overcome things such as the Friedman curve. And so what's shown here is how women used to deliver babies back in the 40s and 50s. It was often under sedation. And at some point, doctors wanted to identify how quickly does labor normally progress. And so what they did is they ran a study to look at what normal labor progression looks like by examining a woman's cervix over time over the course of her labor and delivery. And from there came the Friedman curve. And the consequence of this curve is that it has been used as essentially the gold standard to normal labor progression for all women throughout the world. And the number one reason for unnecessary C-sections is what they call labor arrest, so failure to progress in labor, which is based upon this Friedman curve. Now, the problem is, of course, is that, first of all, the study took place in the 50s, and one might assume that a lot of aspects of women's lifestyle and the sort of the bodies may have changed in that period of time. But the bigger problem is that this study was an observational study that took place at Columbia, a single site study with 500 white women. 90% of them were sedated. And we've been using this as the gold standard until about 3 or 4 years ago to determine what normal labor progression looks like. So this is a huge, huge, huge problem, and the consequences we've been feeling for decades and decades to come. And so at Bloomlife, really what we're trying to do is develop the future of prenatal care, combining connected devices with data analytics. And through connected devices, be able to have comprehensive remote monitoring of maternal fetal health. With that additional data, you'll be able to do a better job of both risk stratification, and through better risk stratification, be able to tailor interventions to address modifiable risk factors individually which can lower the overall risk of an adverse event happening, such as a preterm birth. And furthermore, develop digital biomarkers that allow us to identify critical events to reduce the burden of things such as preterm birth and stillbirth. At the center of our solution is a medical grade sensor that allows us to track various physiological signals of maternal fetal health. What the patch does, it's a patch, it's worn on the belly, as you saw in the last photos, and we measure electrophysiology. Specifically, what we're looking at is maternal EKG, fetal EKG, and maternal EHG. And with those signals combined with fetal heart, with an accelerometer, we're able to measure both things that are used in clinical practice today, things such as contractions and fetal heart rate, as well as look at other factors that are either doctors ask women to track from home or have been shown in clinical studies to impact chances of adverse birth events. And how we've approached this space is really, again, the idea of accelerating medical discovery by capturing data at an unprecedented speed, cost, and fidelity. And so as we develop this product, our North Star has always been integrating the healthcare and defining new standards of care. But to collect data, what we started is follow almost a 23andMe based approach, and to launch this initially into the consumer space as a sort of non-diagnostic product, sort of for peace of mind. With that consumer product, we've aggregated a large data with real world outcomes reported by the mom, and have used that to train machine learning models to start doing this risk stratification and identify specific combinations of physiological features that allow us to identify or predict events. And now we're at the stage where we're starting to take these new tools, and I'll talk about what they specifically are, through the FDA to start driving clinical utilization, eventually payer coverage of it. So our first product that we launched out into the world was the device you've seen there. It's a product that simply for the patient allowed us to automatically track and time contractions. It's primarily been used in the third trimester to provide a validated second opinion to the patient to help them understand what they're feeling, help them more easily communicate with their care team, and to make the appropriate decision on when or when not to go in. What we've learned since launching this product in early 2018 is that for sure women want to have access to more information. Certainly there's the case where most women are going to know definitively when they're in labor. There's a lot of indecision that comes before then of just helping to understand what is a Braxton Hicks, what's not a Braxton Hicks, and for women that might be in early labor, to identify when they might be going to early labor. And again, for women that might be going to preterm labor, early identification is super critical. So we've seen a very passionate group of people. We've also seen that when providing women access to information, that you can in fact reduce anxiety and increase empowerment. There's often the concern, and I think the rightful concern within the medical community, that if you give a patient information, they're not going to know what to do with it. It's going to stress them out. All it's going to do is increase the overhead on them. And what we found is that if you design these things appropriately, if you do the right information architecture, if you do all the human factors, you're seeing increasing anxiety, decreasing anxiety, increasing empowerment, and allowing the woman to more effectively communicate with those around her on what's happening, which of course can improve quality of care. The other thing we've learned is that real world data can in fact seed biomarker discovery. We've served over 12,000 women throughout the US. These have been low risk and high risk pregnancies. And through these pregnancies, we've now aggregated over 800,000 hours of longitudinal physiological data on mom and baby. And I say mom and baby is, while we show the woman uterine activity, what we measure is all the raw physiological signal, which includes maternal and fetal data. And we use that all for our biomarker work. To give you an idea of how big this data set is, the next largest data set that exists out there in this space has about 500 hours and took 8 hours to so about 500 hours of data and took about 8 years to collect. So we're talking orders of magnitude larger. And with a much more sort of longitudinal view to it instead of just sort of episodic 1 hour, 2 hour recordings. A little bit more about the data set. We have been looking at all the physiological data on mom and baby paired with real world evidence on birth outcomes. Within our data set, we've had about 29% of our users have been high risk moms. About 28% have delivered early. And then interestingly, again, this is a product that people have been paying for out of pocket. About 46% of our users were in rural communities. And I think when we first were sort of ideating and building this business, we felt that it might follow kind of typical tech adoption curves, a lot of kind of like, wealthier moms in kind of urban or suburban communities. And we were really both surprised and happy that we were seeing 46% of our users were in rural communities. And again, I think it speaks to the acute need of these women that live so far away from their doctor or from a hospital to have better information at their fingertips to make the right decision for them on what to do. And again, so that's something that's interesting. So in terms of what we've done is we took this large data set with these real world outcomes, and we applied machine learning to completely evaluate the EHG signal as well as the mom's cardiovascular signal. And what we found is that we've been able to develop essentially a digital biomarker that allows us to identify labor onset. This was developed with a training data set, which was based upon the consumer-generated data, and then subsequently validated in a prospective study that was funded by the European Commission. And through that study, we identified that there was essentially 17 physiological features that, when combined, allow us to identify labor onset with the same accuracy as a doctor giving a clinical exam. And so today, the way that they diagnose labor is the woman goes to the hospital, they hook her up to a device called the one that I showed you before, the cardiotocogram. They measure contraction frequency, and the doctor gives her a pelvic exam and sees whether or not her cervix is dilating and effacing. And what we've shown is that there's a combination of physiological changes that occur in the coordination of the uterine muscle and the activation of the mom's sympathetic nervous system that allows us to identify labor onset with a similar accuracy. The implications of this from a clinical setting are that it really opens up the possibility of improving intrapartum care. Intrapartum care is the time from the woman goes into labor to the time she delivers the baby. Within maternal health, that is usually where about 70% of the costs are. And they sort of break down roughly into sort of these kind of big buckets here, which is one is women going in unnecessarily for false labor. You could sort of imagine how this might happen. Overall, this happens about once in 30% of pregnancies. And every time it happens, it costs the insurance companies about $1,000. And so in general, it's costing healthcare, broadly speaking, in the US about $1.2 billion per year. And so having a tool that helps women identify labor from false labor can start to reduce that. The second thing we're looking at is unnecessary C-sections. I already mentioned this idea of labor arrest. That is one sort of manner of which we could start to reduce C-sections. The other one is looking at preventing women from going in too early. And so there's a large body of evidence out there that have shown that when women go to a hospital too soon, that it triggers a series of events. Oftentimes, there's a sort of a negative feedback loop in terms of the progression of labor due to stress that causes labor to slow down, which triggers sort of interventions to accelerate labor and sort of all the cascading events through there. And so we have a study right now with OHSU looking at reducing unnecessary C-sections rates by being able to better stage where our mom's at in labor, looking at the sort of the physiological changes that we can measure. And then the last one is, of course, around preterm birth. And in this case, it's really about earlier identification of spontaneous preterm labor and making sure that mom can get to a hospital as quickly as possible. For us in the Bay Area, getting to a hospital that has all the right facilities is pretty easy. They're all around. You could think about a mom again in a rural community that might live several hours away from a hospital might be a problem, let alone a hospital that's equipped to support a preterm birth, which is a tertiary care center, and not all hospitals are equipped for that. And so this is another avenue of research that we're looking at. We have a study that's going on right now to be able to look at our ability to appropriately identify spontaneous preterm labor. And so moving forward, really, it's about starting to take this tool that started off with the consumer space and really translating that into a clinical tool, such that it could be a device that's prescribed in the third trimester for remote monitoring, could be worn daily by the mom to provide both her feedback and establish baseline data through which our machine learning algorithms could start to detect those abnormalities and start providing the concise reports and actionable reports to the doctors, so mom and doctor could act appropriately to start to address some of those clinical problems that I mentioned. But this is sort of where we're at today. I mean, moving forward, there's a whole host of other things that we look to do, not just around third trimester intrapartum care. We're really thinking about a tool that can be used really from the first trimester onward to continue to look holistically at maternal and fetal health, starting even to pull in data from other third-party devices, whether or not that's blood pressure, weight, blood glucose meters, further self-reported information from the mom, to continue to capture this very comprehensive view. And for things such as preterm birth, be able to improve our ability to individually identify for a given mom what her risk factors might be for something like preterm birth, and be able to tailor interventions accordingly to her to take a mom that might have a 30% chance of delivering preterm and move her into like 18 or 15% chance. And as a consequence, be able to really start to shift outcomes in this critical space. So with that, I'll wrap up and be happy to answer any questions anyone has.
Great, thanks so much, Eric. So, excellent talk. And yeah, everyone, if you have any questions, please raise your hand and I will unmute you and you can ask your question directly, or feel free to add it in the Q&A session. Comment on the bottom of your Zoom. It looks like Anoop has been answering questions kind of as we've been going as well. So yeah. So yeah, I'll start off, I guess, go down the list here of the ones being typed in. It says, this one's for you, Anoop. Could you speak to remote monitoring and its importance in neonatal care, i.e. remote PPG detecting heart rate, respiration rate, and other vital signs?
Yeah, there are different modalities of capturing information, and PPG is one of them. There are lots of devices out there that utilize PPG for capture, and there are pluses and minuses to think about. So one of the things that happens in the ICU often is that the ambient light changes quite a bit. Sometimes you're exposed to natural light, sometimes it's artificial, sometimes you have phototherapy, blue light in the 450 nanometer range. So with such fluctuations in ambient light, sometimes PPG can be a little bit deceptive, but to overall put it in context, I think there are various ways of computing these parameters, and PPG is certainly one of the leading ones out there. So that's what I would suggest. And like I said, there are quite a few devices out there that use PPG to be able to compute.
Right, thank you for that. Arut, please go ahead and ask your question directly.
Okay, Anoop and Eric, it's a great talk. And I have a question to Anoop. So the fabric sensor, which is the one sensor in the fabric in a specific area, or multiple sensors are there, and then this data is remotely collected to any phone or any other device or something. I just want to know, like, it's a great device.
Yeah. So thank you. I think the prototype device that we have used currently to collect data is a wired sensor. We have a wireless configuration that's ready, but because of COVID, we have not been able to use it. Big picture, it's just the electrode. I mean, the typical electrode configuration, think of electrodes being stuck in a very specific geometric location on a fabric. So think about it that way. So it's essentially one sensor, but then the sensing elements are kind of split apart because you want to have the electrodes pick up signals from different parts of the body. Thank you, Alice.
Yeah, thank you.
Great, thanks. Let's see, well, let's go on for Eric. Says, I'm curious if you're pairing any of the wearable data from your devices with omics sequencing data.
Yeah, so that's definitely an area we want to continue to pursue. Currently, we're not pairing with any of the omics. That's, again, I think that's continue to build orthogonal data sets to better triangulate and build more predictive models is an area we're looking into. But currently, no, we're not pairing it with any omics data, but interested.
And then I guess another question for you, Eric, is what's the status of the Bloomlife? Is it on sale in the market or just samples for test?
Yeah, so we were on the market from 2018 till beginning of 20 till just the end of 2019 as a sort of self-pay subscription to patients or to consumers. As we started to kind of shift towards a FDA cleared product, we have stopped offering that one to continue completely focus on the medical version of the product, or what's called the FDA cleared version of the product. So currently we do have samples if people are interested in testing out the product or using it. We do have devices that could be sent out for testing.
Okay, excellent. Let's see. We'll go for Anoop. Are there any need for new sensor modalities in this space? Any need that is not currently met?
Quite a lot. It's a can of worms. No, I think there are quite a few. If I were to single out one, and that's perhaps my personal favorite, is I would say something like a transcutaneous, a skin-based partial pressure of oxygen, PaO2 measurement, would be very, very interesting for us because it allows us to sample less blood and be able to make clinical decisions for the baby in a less invasive way. So in other words, a transcutaneous PaO2 measurement device. There are many more. This would be number one on my list.
Okay, excellent. Let's see. Also, another question for you. I wonder if you know of any micro and nano devices developed for monitoring or measuring neonatal signals. So micro or nano devices.
Kind of payment. We can definitely touch base offline so that I answer your question specifically. If you're purely talking about the size of the device in being super small to be able to monitor things, yes, there have been devices been used over the last couple of years. Some of them are micro sensors that are used for blood sampling, but I'd be happy to connect offline to specifically answer your question so that I get it right.
All right, great, thank you. We'll switch back to you now, Eric. Let's see. Why are the pregnancy-related deaths rising in the U.S. while dropping in other developed countries?
That is a very, very, very good question. And much like a lot of pregnancy aspects, it's kind of multifactorial. The deaths are not, by the way, increasing uniformly across the board. It's kind of a very topical aspect. They are disproportionately affecting women of color, specifically Black women. So in many ways, I think folks believe that there is an aspect of institutional racism within healthcare that's affecting it. And in particular, doctors just not listening to women, them saying something's wrong and they're not feeling well, and their concerns being dismissed in many ways. So when they classify it as maternal death, oftentimes it's both, it's either during pregnancy, intrapartum, or even sort of the time immediately thereafter. Postpartum hemorrhage is one of the biggest causes of that. And again, sometimes it's a doctor's not listening to women or the clinical staff not listening to women. Other aspects, it's just not really best practices being instituted at a lot of facilities. And so it's again, it's a multifactorial issue. But that's yeah, so.
Okay, yeah, absolutely. Let's see. Also, can you speak to data privacy concerns for patients, providers, obstacles in building of the database?
Yeah, sure. I mean, we've always taken the perspective, I guess, philosophically, that the patient's data should be their own, and so everything should be opt-in in terms of sort of sharing data from a larger kind of biomarker discovery perspective. That being said, of course, there's all the things you would want to do in terms of ensuring privacy of patients. In our case, individual patient name and contact information is less relevant than the physiological data we have, the outcome that happened, any other risk factors that may have had. And so there's the ability to completely identify data, and that does not at all affect our ability to do our biomarker work. But I think it's definitely something that we are very mindful of and try to be as transparent as we can, and also build out eventually downstream the tools so that there's more of a variable opt-in, opt-out. If I say I've opted in now, but I decide later I want to opt out, that's still possible to go back and scrub their data. And of course, GDPR has been a good driving force. I mean, we have our team is in Europe right now, and so we've had to be GDPR compliant from the start of this. And so that's the kind of way that we think about it.
Thank you. Anoop, it seems that these types of monitors could save money for hospitals and insurers. Why are they private pay? Oh, I think you muted yourself on accident. Oh, let's see.
I must agree with Donna. I think, at least for the devices that I talked about, the reimbursement strategies are are things that still need to be worked out, and it's definite thought that all of us focus on. It's tricky sometimes how hospitals operate. In a fee-for-service system, as many of you may appreciate, that billing is is one way of actually making money, and hospitals that are fee-for-service versus other forms where you're looking at cost-effective types of care, the thought processes are very different. And I think, Donna, I'd love to connect again offline. The incentives are very, very different. And as much as we'd want to think that the overall cost of care needs to go down, the ability to, the way hospitals and the administration operates, the line of thinking is very, very different, diametrically opposite to what many of us might end up thinking. So it might make logical sense, but it might not make fiscal sense for many of the hospitals. So these perverse incentives are things we need to think about at length.
Yeah. If the cost of care is going down, money's coming out of someone's pocket, and that person is going to have a disincentive for that thing to kind of get adopted, unless there's payment reform.
So to support Eric's point, just given this COVID situation, for example, a lot of care transitioned to the telemodel of care, and you can pretty much see that other reasons apart, revenues just plummet because reimbursement is not as much as one would expect. But you and I would find it very convenient to actually get our doctor very quickly on a telecall. It doesn't make financial sense for hospitals because of that example that I showed you. They've put in 150K, 200K in just one single bay in the hospital. They have to make money to be able to recover that. And so it's like very expensive real estate that's sitting empty. Hospitals make money when they are full. And if people are healthy, hospitals don't exist. Shortly after lockdowns were initiated, somewhere about 2 or 3 weeks after that, we heard a lot about Lyft and Uber and everybody sort of going through the furloughs in large companies. About 107 hospitals in non-mainstream cities essentially went bankrupt during that time, within a very short period of time. So you can imagine what their margins are and how survival clearly depends on billing and billing practices. Sorry, long answer, Donna, but kind of drives home some of the fundamental issues in the state of healthcare in the US and many other countries.
Yeah, we appreciate all these great insights. Yeah, and also kind of from the patient perspective. So for pregnancy, it's very uncomfortable for the moms, baby. The question is how comfortable moms feel about these devices based on your studies.
Yeah, I mean, they're small, they're discreet. We took a lot of care to design the adhesive. In fact, that was one of the biggest challenges. I've got some horror stories of early days testing with adhesives that were too sticky and having some problems of let's say, marking women's belly where we were not trying to. Overall, I mean, I think so far from a comfort standpoint, we've seen most people, when they wear them, they kind of forget they're on. I think we've had to address up front some of the safety concerns, because I think obviously anytime you're putting something electronic next to your belly, the most precious thing in your life, then there's always some concerns there. I mean, the way that the device works is completely passive. We don't inject any energy into the body when it's listening to electrical activity. And we do a lot of safety testing around specific absorption rate to make sure any electromagnetic energy coming off the device, for instance, from Bluetooth to energy radio, does not in fact go into the body. And so we take a lot of concerns, I mean, given the area we're working into, to both think about comfort, think about safety, and also think about usability. The device is placed in a part of the body that the woman can't necessarily see. And so we kind of think a lot about usability of the product and how do you actually provide instructions so the mom can place the patch at the appropriate location for us to take a clinical labor. So just a lot of human factors work has gone into building out the
Okay, great. Thank you for that. So I guess just one last question that's for you, Eric. Are you able to identify TPL earlier? And if earlier use of tocolytics seems to be improving efficacy?
Yeah, that at a high level is the billion-dollar question, right? I think part of the challenge within preterm birth right now is in many ways obstetricians take a bit of a nihilistic mindset and they say, well, we can't do anything anyway, so who cares, right? There's nothing we can do. Let's just I mean, it's going to happen. So who cares if we protect it? Which of course is one line of thinking, but I mean that doesn't really move science and medicine forward at all. And I think so. The way that we look at it is that if you actually had a tool that could earlier identify the earliest signs of spontaneous preterm labor, for sure you can improve downstream care coordination, and that might mean earlier delivery of tocolytics, perhaps. That could also mean more timely and appropriate usage of corticosteroids. So I think there's a couple different things that open up from an avenue of research standpoint, let alone just making sure, again, the mom is getting to a hospital that's equipped with a tertiary care center in case the baby is coming early. So I think that the hope is that with early identification paired with earlier interventions of what's available in the doctor's toolbox, that we could start to see some improvement in care. And it comes down to both early identification and not just the sensitivity, but the specificity as well, and trying to help care providers rule out non-preterm labor. Since right now, it seems like we're overutilizing corticosteroids in many ways. And from all the literature that we've been able to dig up on this, that your first use is your best shot, and the second shot isn't quite as effective as the first one. And of course, giving someone corticosteroids may have downstream effects that we don't even quite wrap our head around yet. So I think there's definitely some interesting avenues to see how we can start to affect preterm birth outcomes.
Great. Well, thanks so much. I mean, it was really a pleasure having both of you, and we really appreciate all your great insights and contributing to our seminar series, and hope to continue to stay in contact and be linked to PHIND and eWare. And thanks also to Angela for helping co-host this event. Of course, Ashley as well. So
thanks so much, Ryan.
Yeah, thank you. So we look forward to seeing everyone at the next seminar, and everyone have a great day. Thanks so much, everybody.
Thank you.
Thank you.